Oh, was that you or me?
Go.
Yeah, I did it. Sorry.
Oh,
Okay, that's fine. We'll talk with Bruce afterwards. Thanks.
okay. So, 20 more people. We can get started. I will stop sharing, and Dr. Scott, you can share your screen. So it is, I'll introduce myself again. I'm Rebecca Stamen. I'm one of the peds epileptologists at Nemours, and I'll be co-hosting this with Romy over the next several months. And it is my pleasure today to introduce Dr. Rodney Scott. I'm very familiar with this since he is the division chief of neurology at Nemours Children's Health Hospital in Delaware, where he also serves as the director of the neurosciences unit. He obtained his medical degree from the University of Zimbabwe and his PhD from the University of London. He then trained in pediatric neurology at UCL, Great Ormond Street Hospital. And his work straddles the interface between basic and clinical science, focusing on the care of children with epilepsy and their cognitive and behavioral impairments, and approaches his work with thinking about the brain as a complex adaptive system, which has informed his research work. And so today he will be talking to us about current concepts in DEE. So take it away.
Great. Thank you very much, Rebecca. So thank you very much for the invite. I'm delighted to come and talk to you about developmental and epileptic encephalopathies. These are disorders that really represent the most challenging of patients that we see in pediatric epilepsy. And therefore, I think it's important that we think deeply about them and how we might be able to move things forward. So what I want to do today, I'm assuming my slides are moving, is give you some historical context and try to tell you a story of how we've moved over the years from thinking about epileptic encephalopathies primarily as a phenomenon that's related to an epileptic discharge or seizure, to one that also incorporates the idea of developmental diseases and the rise of genetics. And then I'll spend some time talking about the limitations of our current approaches to developmental and epileptic encephalopathies, and try and persuade you that thinking about the brain as a complex adaptive system and reconceptualizing things comes with advantages in terms of how we think about DEEs. So the idea of an epileptic encephalopathy was first used formally in the literature by Henri Gastaut in 1966. And he described this very familiar idea that we have, that epileptic activity contributes per se to adverse neurodevelopmental outcomes in patients who have epilepsy. It stayed as an idea for quite some time before it was included into the ILAE classification scheme in 2001. And then as the rise of genetics came along, the terminology changed again to be developmental and epileptic encephalopathy. And this is the terminology that we currently use for these disorders. So I think it's important that we think about how this term is used. It's really being used in two complementary ways, and I'm going to emphasize the top way during the course of this talk, although I'll also think about the second way a little bit. So the first statement is really the Gastaut statement. It's a pathophysiological phenomenon that says epileptic activity is harmful irrespective of the etiology. There's something inherent inside epileptic discharges that makes them harmful to cognition. And the example where we might think about this is focal cortical lesions in children undergoing epilepsy surgery. So even though they have single unilateral, reasonably small focal lesions, these children often have global developmental delays and associated behavioral and psychiatric conditions. And the idea is that the epileptic seizure or epileptic discharges are in some way contributing to those outcomes. The second way we think about it is a classification scheme where those children who have very challenging epilepsy, multiple seizure types, challenging behaviors, etc., are classified as having epileptic encephalopathies. So we think of this infantile spasms, Lennox-Gastaut, Dravet. And even within that classification scheme, there's still an underlying view that the epileptic activity is harmful. So let's start by asking whether, in fact, there's a relationship between epileptic activity and cognition and behavior. And there's a huge amount of literature showing that children that have epilepsy are much more likely to have cognitive and behavioral impairments. What I'll do throughout this talk is pull out individual studies which are representative of the thing that I'm trying to tell you about. In no way is that going to be a complete description of the data. So this was from the Childhood Epilepsy in Sussex Schools epidemiological study that we did when I was in London. So this is all children in Sussex Schools were identified with epilepsy and were seen after identification by an educational psychologist and a psychiatrist who did a whole bunch of behavioral testing and a whole bunch of cognitive testing. So I assume that you can see my pointer. Okay. So in the background here is an expected distribution of IQ scores. And you see there's really two populations of children here. There's a population that fall inside that distribution, and then this very, very heavy tail of children who have cognitive impairments, many of whom have very severe cognitive impairments. So there's clearly a relationship between seizures, well, between epilepsy and cognition here. And if you look at behavioral disorders, so the psychiatric disorders, in the same group of children, we identified those that already held a psychiatric diagnosis, and then in fact tested them against DSM-4 criteria and showed that the children in Sussex Schools, all children with epilepsy in Sussex Schools, 60% of them had some behavioral impairment. So autism spectrum disorder, ADHD, DCD. We see less depression in childhood than I think the adult neurologists probably see, although we do see some anxiety. So it's clearly a relationship. I'm not in any way going to dispute the observation. However, the observation really did lead to clinical consequences. It led to very aggressive attempts to stop seizures. High doses of anti-seizure medications, polytherapy. I've seen children on 6 and 7 and 8 anti-epileptic drugs simultaneously. Use of unusual agents like prednisone, so high doses of prednisone over 6-week periods, sometimes using it intermittently over longer periods than that, and a growing emphasis on the identification of subclinical discharges, chasing EEGs, chasing EEG and autism, et cetera, et cetera. I would argue up front that none of this stuff has been beneficial to patients, that all of this simply led to increased side effects, worsening quality of life. And I think it's a real shame that this is what that particular concept has done. So if I'm concerned about what the concept has done, I need to at least challenge the concept. So this is the way we're asked to think about it, that there is some seizure burden, whether that's clinical seizures, epileptogenic discharges, and as that seizure burden goes up, the proportion of children that have adverse outcomes in terms of their behavior and cognition goes up. And this is enticing because what it says is if you treat the seizure burden, then you'll be able to reduce the proportion of children who have cognitive impairments. So this is a graph that would kind of correspond to that. In fact, what it really is real data from a study looking at ice cream sales and murder rate in New York City. And if you want to apply exactly the same concept, exactly the same strategy to the data now, you'd have to say the way to reduce murder rates in New York City is to close ice cream shops. And that clearly doesn't make any sense at all. There's nobody that's going around promoting that particular idea. So what we're really talking about here is the difference between correlation and causation. So I'm not disputing that there's a correlation between having bad epilepsy and having a cognitive impairment. What I'm disputing is that there's a causative relationship. So has anybody attempted to show causation? Well, yeah, this has been done a lot heavily by Greg Holmes's group. And there are several ways in which you can try and establish causation. So the first and obvious way is to take a rodent model. So these are baby rats that were exposed to an inhaled agent called fluorothil. And when the animals inhale fluorothil, they have epileptic seizures. They last about a minute. And you can give 5 to 10 seizures per day over a 5 to 10 day period while the animals are babies. So they're usually P5, P15-ish sort of age. There's a range of ages you can do it at. And then you let the animals grow up. So the idea of the epileptic encephalopathy is a seizure is doing something to the brain. So once the seizure is gone, you expect the brain to be dysfunctional. So Greg let the rats grow up. He then tested their cognitive ability in a Morris water maze. So this is a spatial cognition task, which really is like thinking about episodic memory. And he showed in one of his early studies here a huge difference. So the animals that didn't see seizures were very good at finding a platform. They were very good at understanding space. Those that saw 50 seizures did much worse. I have to tell you, that's by far and away his best data. I've never seen him publish anything better than that. What I see much more frequently is things like this. So here he did a very similar experiment, but he wanted to test whether there was an age dependency. So he gave 50 fluorothel seizures either between day 0 and day 10 or between day 10 and day 20, which is the groups E1 and E2 here. And there is a significant difference, primarily on the first session on any given day is where he saw most of the effect. But here it's much less obvious that these animals were actually cognitively impaired. And this doesn't really jive with the children that I see in my clinic who are really cognitively impaired. So some evidence may be that if you induce seizures in the context of a non-diseased brain, you get some small impact on behavior. However, the epileptic encephalopathy hypothesis was much more than seizures. It's also the idea that the subclinical discharges, ongoing subclinical discharges, are harmful. So he developed this other model where he was able to make interictal discharges with low doses of continuously delivered fluorothel, inhaled fluorothel. So these animals actually were EEG monitored on this occasion. And they got small amounts of fluorothel for 4 hours a day for 10 days. And during that 4 hours, they were having a lot of epileptic discharges. He also wanted to see whether there was an effect of stopping the discharges. So he had another group where the animals were also exposed to isoflurane and fluorothel plus isoflurane group. So they saw the fluorothel, but they didn't have epileptic discharges. And I don't know if any of you are thoroughly impressed by this set of graphs, but I'm not. This looks very much like this, at best, a tiny effect. So this is 40 hours in a rat of continuous interictal EEG abnormality with very little effect. So I took all of this to say seizures are probably not as harmful as we think they are. And there was a big issue with this. So there were two issues, really. One, the data didn't really jive with my clinical experience. And two, these were all discharges in the context of normal brains. And normal brains don't make these seizures. There's something different about an abnormal brain. So I ended up going to Greg's lab on a sabbatical. And what I wanted to do was try and bind those two things together. I wanted an animal model of a brain disorder that was associated with seizures, but didn't have frequent epileptic seizures, that I could then induce seizures on top to see if there was an interaction between having a brain disease and the seizures. So the thing we chose to go after was a malformation of cortical development. So we used the methylazoxymethanol model, which is MAM, which you inject into pregnant dams at E15 or E17. Animals are born with a malformation of cortical development. And then we exposed them to seizures in exactly the same way as Greg has done previously, tested them at P25 and 28, and then tested them as adults at P45. And I'll just cut to the chase. So if you look at them when they're adults, you get the green line, which is normal animals. You get normal animals with discharges who are less good. Okay, so I'm showing this in a slightly different way. This is now a time to event analysis. This is how long it takes for an animal to find the platform in a water maze. And there is a small effect, kind of consistent with what Greg Holmes has seen. But this is the one that's important. These two lines here, the heavy lines are animals that have malformations of cortical development and no seizures. And they're really way, way worse than the controls. And when you add seizures on top of it, it doesn't make the blindest bit of difference. These animals are exactly the same. So a malformation of cortical development with additional seizures did not make cognitive impairments worse. Okay, so I'm clearly arguing against the idea that epileptic discharges per se are harmful to developing brains in a way that leads to cognitive and behavioral impairments. But maybe it's about the discharge itself. Maybe it's about at the time the brain is making a discharge, it's not able to compute, it's not able to make cognition. So we wanted to test that particular idea. This is work done by John Clean in a task called a delay non-matched to sample task. So here rats are put into an operant chamber, and they're taught to do this particular task. What happens is they wander around in the chamber, and then a lever comes out of the chamber, and the rat has to press it and encode that. So he needs to remember which lever he's pressed. We then determine how long he has to wait, and he has to wander around in the cage, break an infrared beam on the other side of the cage, and after a period of time that we define, 2 levers come out, and the rat needs to be able to press the opposite one. So it's a non-matched to sample task. So we had rats doing this, and they had been exposed to pilocarpine, so they effectively have mesial temporal sclerosis. So they have seizures, they have discharges. They're doing the task, and then we're able to determine at which point during the task epileptic discharges were occurring. So if they occurred at this point, we said they had was encoding, maintenance, sorry, I'm on the wrong screen, encoding, maintenance, and recall. So what you see is as we force the length of time that the animal has to remember the lever press for longer, they get less good at doing the task. This is a known effect of this task. However, if you look at the success rate, the accuracy of the animal, at the time that epileptic seizures, at the time that discharges were occurring when there was encoding or during the maintenance phases, these lines are directly on top of each other. If you look at if a discharge happened at the time the animal had to retrieve the information, there was a sudden drop-off. So you could say, well, maybe it's because each of these discharges add up in time. If you have 1 discharge, yeah, not much of an effect. If you have 3,000 discharges, 3,000 times an effect. That's kind of impressive. So we did it in humans. So here is now looking direct impact of intrarectal discharges in humans. This is a Sternberg task. So here the individual's asked to look at the cross. We then show them a list of letters. There's another distractor. They see a letter. They have to say whether the letter was in the previous list. And again, you can do exactly the same thing. It's set up in exactly the same way. You look at the timing of the discharges. And what you see is if there are interictal discharges in the hippocampus, which is the epileptogenic zone, then there's no effect at all. And we interpreted this as this is not an effective hippocampus anyway. It's not doing anything. But if there happen to be discharges on the contralateral side or bilateral discharges, then it had a significant impact on how well the person was able to retrieve information. Again, this was heavily based in the retrieval phase. So now this is looking really good, except in the paper we wrote this result and ends up not being reported very much. We did exactly the thing that we're concerned about. We looked at the total number of interictal discharges in any given Sternberg session and related it to how well the person did in the Sternberg session, and related it to IQ, and related it to the Cavalt, and amongst many other things. And there's no relationship between the number of discharges and those pervasive phenomena. So if you have an epileptic discharge in the right place at the right time, then there's a disruption to cognition, but that doesn't generalize to patients with cognitive impairment. So I didn't persuade myself that we established causation out of all of this stuff, but we didn't certainly establish causation in a way that made me comfortable that we're looking at epileptic encephalopathies. So an alternative way to think about it is, well, can we take the thing away? Can we do the inverse? Can we make our patients seizure-free and show that they get cognitively better? And again, there's a lot of data out there. Most of it is negative. Most of it doesn't show anything. So in fact, I'm being generous by showing you the one paper that perhaps shows something. One of 2 papers. So this is Torsten Boldewig's group at Great Ormond Street. They've been looking at the Great Ormond Street epilepsy surgery program for a long time. This is like 500 children, recently published in Brain. that had pre-surgical cognitive assessments, post-surgical cognitive assessments, follow-up over time. And the thing that they want you to take away here is if you look at the controls, they're in the patients who became seizure-free, not controls. Patients who became seizure-free are in the green, and patients who didn't become seizure-free are in the orange. So over the course of 10 years, you get on a median 6 IQ point gain if the patient becomes seizure-free, and a chunk of that IQ point change happens when patients reduce anti-epileptic drugs. But nevertheless, we can be generous. You get a 6 IQ point change. And if you don't become seizure-free, you have a 2 IQ point change. So this suggests there's a difference in trajectory, but they've shown us the trajectories. And in fact, there's something very interesting about this. Just about all of the green is at the top. So just about all of the patients who became seizure-free were already cognitively more preserved than the patients who didn't become seizure-free. This kind of isn't that well known. And we tend to not think about this, something that probably needs some further thought. But what they are trying to make a case for is a trajectory. So they've put the trajectories. Here's a seizure-free trajectory, and here is a not seizure-free trajectory. And you'd have to go some way to persuading me that those lines are not parallel to each other with the 95% confidence intervals on it. So the trajectories, in fact, haven't changed. So even in this frame, and I'm being generous, you might get a small cognitive improvement, but in a big cohort, you're not seeing a particularly dramatic change in trajectory of cognitive improvements over time. So again, there's no evidence of improvement, but maybe what you did was stop patients from getting worse. So the way this tends to be seen now is like this, that you have an epileptogenic pathology, you start epilepsy, you get an epileptic encephalopathy, you have surgery, you get some cognitive recovery, but you continue to be delayed because there's some underlying epileptogenic pathology. So this now moves us away from some extent from the idea that the discharge is the thing. And we now need to be thinking about the difference here. Before we do that, I just want to point out that if you look at the behavioral things rather than the cognitive things, this is a quality of life evaluation in the Ann Berg, Connecticut study, looking at kids who became not seizure-free and seizure-free on a community basis, looking at a whole bunch of things that include self-esteem, behavior, family activities from a child and a parent perspective. And again, the seizure-frees are not different. So that's really thinking about it as a pathophysiological phenomenon. And doesn't seem to hold much water in that frame. So let's think about it as a syndrome. Is there something about these syndromes? Can we identify children that have similar seizure frequencies, similar ages of seizures, similar types of seizures, and show that some are good and some are bad? And the answer is yes, we can do this. So you can get benign neonatal familial convulsions, kids do well. Hypoxic ischemic encephalopathy, kids do badly. Childhood absence epilepsy, kids do well. Lennox-Gastaut with lots of absence attacks, they do badly. Benign Rolandic epilepsy, frequent interictal discharges at night, they do well. Landau-Kleffner, frequent interictal discharges at night, they do badly. So again, it doesn't quite pan out that the seizure is the thing. So what is the thing? The thing is etiology. So now we need to change tack. Even though it's called an epileptic encephalopathy up to this point, this is now building the idea of it's a developmental and epileptic encephalopathy. You need the developmental component here. So in a syndrome orientation, this is now the way we start to think about stuff. We think about these as self-limited epilepsies, and these kids do well. Etiology-specific syndromes, there's some specific treatments in here, pyridoxine, pyridoxamine, ketogenic diet, stage Weber, you might want aspirin, gelastic seizures, you want to take out the hypothalamic hamartoma. These are etiology-specific things. None of that changes cognition, by the way. And then we've made a cluster of children who have developmental and epileptic encephalopathies. And we call these names, including infantile spasms, Dravet syndrome, etc. The question is, what's causing the developmental piece of the developmental and epileptic encephalopathy? And this is really the rise of genetics. So if you look at the timescale here, in 2001, when we're heavily thinking about the seizure, there were hardly any genes. By 2020, when we're talking about developmental and epileptic encephalopathies, there's tons of genes. So all of these genes have been identified over time, and we're up to 500-ish, maybe more, gene mutations and thousands of variants and a whole bunch of stuff which is not even related to a direct mutation, copy number variants, for example. So it's worth asking how those are distributed. So what you get is a few genes, PRRT2, SCN1, 1A, KCNQ2, which are found reasonably commonly. So this is a sample. I think this one's from from Glasgow. But what you end up with is a lot of genes of people where you're going to have 1 or 2 or 3 or 4 individuals that are having that mutation. So we kind of have to think about how all of this is going to work. How are we going to formulate this? We've got 500 genes, and we've got epileptic encephalopathies, and we're concerned about the developmental piece. So we want to catch up the developmental component, not only the epileptic component. So the way we tend to think about it at the moment, implicitly, although when I ask people explicitly, they always say this isn't the case, but implicitly the way we're thinking is this. You've got gene 1, it leads to epileptic encephalopathy 1, gene 2 to epileptic encephalopathy 3, plus SCN1A leads to Dravet, etc., etc., etc. And in this framework, you would say, if I can fix gene 1, I'm going to fix epileptic encephalopathy 1. And it's fine for the top 5 or 6. I don't know how you do that for number 500, because I don't know how you're going to build the gene trick that you need in order to fix the gene in somebody, in the 4 children that have the 500th mutation, for example. So it's a nice idea. And it really brings up this idea of the promise of personalized therapies. And this has been very attractive. This has captured a lot of people's imagination. There's an awful lot of work going on trying to do this sort of thing. So the idea here is that you have a developmental and epileptic encephalopathy. You make the diagnosis. We find genetic studies. We can then do functional studies, do stuff in cell culture, organoids, whole animals, identify pathophysiological animals and mechanisms, be very specific about what we're trying to identify, make personalized treatments, fix DEE, and go round and round and round, we'll fix all DEE. This is a very attractive idea. So let's see if there are examples where that idea holds sway, where it's actually true. So let's start with tuberous sclerosis. Tuberous sclerosis, we understand it. It's associated with epilepsy. It's associated with TANS, so neurodevelopmental abnormalities associated with it. And we have a really good treatment. So everolimus is a very good way of modulating mTOR. And TSC is all about the mTOR pathway. We see one pathway at epilepsy conferences endlessly. It's the mTOR pathway. So we know this pathway. EXIST-3 was a randomized clinical trial to test everolimus with versus standard anti-epileptic medications in children with tuberous sclerosis. And they had an initial trial which really showed a rate that you would expect given any other trial, about a 40% reduction in seizures in about 40% of patients. That's a pretty standard thing. Follow-up study looked somewhat better, but still that was just a seizure effect, and there were no important effects on comorbidities. So it could be glass half full. This is an interesting adjunct. It's specifically treating the mechanism of disease. This is cool. I land much more glass half empty. This is supposed to be a precision therapy. You told me the advantage of me learning about precision therapies is you're going to make my patients better, and it's going to dramatically improve outcomes. It didn't. Okay, one example. Maybe it's going to work in other places. Okay, so let's try KCNT1 disease, migrating partial seizures of infancy. Genetic cause is known. We know that there's a drug that modifies channel function, which is quinidine. It's been tested by a lot of groups in a lot of places. And this thing says treatment responsiveness. And the treatment responsiveness is basically 0. It's the same as any other anti-epileptic drug. It's just a poke. It's not magical. So knowing that particular thing hasn't been helpful. What about gene therapies? What we really want to do is fix the gene. If we can fix the gene, then we'll fix everything. So this is the antisense oligonucleotides for Dravet syndrome. So there's 2 studies that are currently ongoing, the Monarch and the Admiral studies. And the interim analysis presented at the AES in 2022 is the last I've seen. I understand they had something at 2023, but I wasn't there and I can't find what it is. So I'll tell you what it is at 2022. Let's assume it's a bit better at 2023. What they showed was a 55% median reduction in seizures. It's not nothing. It's good. 5 of the 6 children had a reduction from their baseline in seizures. 4 of the 6 had a greater than 50% reduction. So this is all very seizure-oriented. And so far, no information on cognition and behavior. But again, I was told that if you fix the gene, you're going to fix the child. And this doesn't look like fixed child to me. So this idea of one gene, one disease starts to feel tough for me to buy. But I think it's, as an idea, it should still be out there. It's still possible that they're going to find things that work. This certainly deserves some time and effort. But if we think about the genetic landscape of the developmental and epileptic encephalopathies now, what we have is a range of disorders that we call a certain set of names. And what we find is there are many genes per disorder. And even if you take our favorite, SCN1A, which is supposed to be Dravet syndrome, yeah, it's Dravet syndrome plus all of these other syndromes. So SCN1A is appearing all over the place. SCN1A doesn't, in some linear, straightforward way, lead to Dravet syndrome. There's some non-linearity about this. There's some unpredictability about what SCN1A is doing. And in fact, if you look at these kids, they don't look like they have 500 different diseases. They look like they have developmental and epileptic encephalopathies. Just about all of them have multiple seizure types. They have tonic-clonic seizures, they have myoclonic seizures, often tonic and atonic seizures. They're very difficult to treat. They're resistant to anti-seizure medications. They have cognitive impairments that are severe. They almost all need help at school. They frequently have autism. They frequently have ADHD. And it doesn't matter which of the genes you're talking about. This is what seems to be the main feature, the main phenotype that we're seeing in these children. So now we need to think about formulating this in 2 different ways. So the way that I've been trying to formulate it, and although I was trying to be positive, I really find it difficult. I want to be reasonably positive about the idea of reductionism. This has taken us an awful long way in biomedical science. So the principle here, the principle that is, again, implicit in gene finding, is that the behavior of a biological system can be explained by properties of its constituent parts. You can take somebody with Dravet syndrome and you can break it down into their constituent genes and find the broken gene and say that's the thing that's the explanatory property. That thing holds the explanatory property. That's what we're doing. That's how this is thought about. And we're thinking about this as a machine, or in fact, the way we want to fix it is with a magic bullet. We want to break it down into its constituent parts, find the thing, have a magic bullet, and the whole thing recovers. So you tend to single out one factor, you give it all of your attention, you give it an explanatory weight, and you say, I know in a linear and predictable way and deterministic way that things are going to get better. This is currently how the one gene, one disease idea is formulated. This feels much more like a watch or some other deterministic system than it does a non-deterministic system like a brain. So what's the alternative? Well, the alternative is to say it's about a system. There isn't one thing. There isn't an element. It's the whole thing. So the principle here is that biological systems possess emergent properties. And those emergent properties are a property of the system. They're not a property of its components. You can't isolate the component. You can study different parts of it. But in the end, the thing you're looking at, for our purposes, cognition and behavior in epileptic encephalopathies are emergent phenomena from the system. So here we're thinking about networks and interactions, and you need to think about many factors being simultaneously evaluated, or many factors being involved in things. It's non-linear, it's stochastic. This is uncomfortable for people. Us in medicine want to be able to say, here's the thing, I'm going to fix it. But in fact, if finding the thing doesn't fix it, maybe we have to now live in this much more uncomfortable space where I'm trying to take you to, which is the space of complex adaptive systems. So here the idea is not so much you have a gene in a disease, you have many, many genes that are doing something to some system, and the box changes, something inside this box is convergent and leading to an emergent phenomenon that looks like epileptic encephalopathy. So now we can say, we can either fix each of the genes, or we can say, what's going on in here? What's in the box? And is there something in the box that we can go after? Is there something in the box that we can modify? And I would say the thing that's in the box is a complex adaptive system. And this is not something to be scared of. There are many, many, many complex adaptive systems in the world, and there are huge numbers of ways of investigating these things and understanding these things. So I want to move you to the brain behaves like an economy or an ecology or a road network or a murmuration of birds. There's no one banker that's able to say, I'm going to fix the economy today. I'm going to drive it up. I'm going to drive it down. This is interactions. There's not one bird that says we need to make this type of pattern. This is simply an interaction of the birds. The pattern of car flow through the patterns of traffic flows are not determined by a single thing. It's a function of the whole thing. Okay, so this is, I understand this is a difficult concept to grasp, but in this world, we don't want to actually find the gene. You don't want to find the one thing. You want to find a way to manipulate the system. Is the brain like this? Well, it's very much so. The brain has millions of genes which are somehow non-linearly related, but undoubtedly related to a microcircuit of neural activity, to regional brain activities, to whole brain activities, to this emergent phenotype, which is the cognitive and behavioral phenotype that we're observing. And we tend to think of it in that direction. We tend to go broken gene, draw a line, end up at behavior. But it's not that way. It also goes backwards. The fact that you are listening to me is changing your brain. You're receiving sensory input, it's changing action potentials going on in your brain, it's changing your auditory cortex. Your auditory cortex is making ARC and CFOS, which are transcriptional factors, changing brain transcription, changing weights of the microcircuit, changing synaptic activity. This whole thing is optimized. So the point is that our brains are optimized to do brain things, and brain things are not seizures. Brain things are learning, memory, movement. So our brains are optimized to do this through this process of emergence and feedback. You end up with this whole system, which is the thing that we're interested in. Now you'll be going, well, what the hell? How are you going to fix that? That's a ludicrous position to take. Okay, but it's not such a ludicrous position. So this brings up the idea of dancing with systems. So this is somebody from Dartmouth called Danella Meadows, who was an ecologist. And according to Meadows, we can't impose our will upon a system. Okay, so the idea that we can take a system and impose a gene, because that's our will, and we know what the outcome is going to be. She says we can't do that. But we can listen to what the system tells us and discover how its properties and our values, obviously not in, in biology, can work together to bring forth something much better than could ever be produced by our will alone. So now we need some sort of feedback. We need to be able to listen to the system, feedback to the system, have some sort of iterative things. We can't control systems or figure them out, but we can dance with them. So now I want to get into the idea of how do we actually do that? Can we dance with this? So the first question that we attempted to answer while dancing with the system is whether cognition can be improved despite no change in structural brain abnormality. So again, we took the MAM animals, they've got malformations of cortical development, and all we did was either grow them up in their normal environments or grow them up with friends and toys. So all we did was change sensory input into the brain. I've just explained to you that sensory input into the brain changes brain structure and changes brain function. Does it lead to improved cognition? Yes. This is the Morris Water maze again. If you take controls, they do well. If you take controls and environmentally enrich them, they do better. This shouldn't surprise us. This is what we're all told we should do. We should brain train, we should exercise, we should do stuff so that we don't get Alzheimer's disease. This is kind of the same idea. If you take the MAM non-enriched animals, they're not very smart. If you enrich them, they're smarter. Okay, so now we're kind of dancing with it. We just changed an environment and watched what happened. We wanted to know more than that. We didn't want to just know what the final outcome was. We wanted to know whether we were actually changing the system. So here we're into this idea of microcircuit mechanisms and understanding microcircuits. So the concept here is that behavior and cognition are a function of the dynamic activities of action potential firing within neural networks. Those patterns, the way neural networks are firing action potentials in time and in space, is actually the mechanism, is actually the system thing that's closely related to the behavior. So we do this. We record single units, multiple single units in rodent models. So this is an electrode. We implant it into the brain. In here are clusters of 4 wires per tetrode. We inject them into we put this into the hippocampus. We fix it. The animals are awake and behaving. We record activity, and we can ultimately extract multiple simultaneously behaving neurons inside this animal while they are doing what they do. In this case, walking around in an open space. While they're walking around in an open space, we can capture certain things, like where the neurons fire. So this is a top-down view of this sort of environment, and this particular neuron only likes to fire when the animal's walking around here and not over here, and you get less and less. You get some neurons that fire like this and some like this. But overall, we know that this is probably coding space, and if you have more of these neurons, the animals are more able to perform well in a task, a spatial task. We also know that when the neurons fire, they don't just increase their firing rate, they increase their firing rate in a very particular pattern. So they fire in bursts at theta frequencies. So you get a burst of firing, and then 120 seconds, a burst of firing, 120 milliseconds, a burst of firing. And we can mathematically model this, and you get something called a post-spike filter. And then you can say, do these neurons fire together in time? Can you build a population dynamics? All of these things are importantly related to outcomes in cognition. So I'll have to speed up a bit. So the single neural dynamics in the animals that were environmentally enriched, what we showed is the spatial coherence improved, theta modulation improved. And in fact, what was interesting is that theta modulation actually predicted how well that same cell was going to be able to code space. So the best place cells were also the ones with the best theta modulation. We wanted to do that again in a different environment. So we went back to the delayed non-match to sample task. We looked at theta modulation in the hippocampus in animals that were that had malformations of cortical development. They had much worse theta modulation. The theta modulation predicted how well they were able to code the lever presses in the same sort of way. So the idea that was percolating here was an idea that if you could drive it, if we can dance with the system in a way that we make that timing thing more theta modulated, then maybe the emergent property that comes out of that is an emergent property that looks like normal behavior and cognition. At this point, we were getting a lot of pushback about the model. Nobody likes MAM. Everybody says it's not a model of anything. It's not biologically relevant. The animals don't have seizures. It's not genetic. So we had to jump. We had to decide which way we were going to jump. And I decided to jump away from the epilepsy world and into the autism world. So it seems to me that all the stuff in epilepsy, the criticisms we were receiving, all seem to hark back to this idea that the seizure is harmful. And if you're not looking at the seizure, then you're not looking at anything. And I, over time, have much more swung my view to, I need to look at the cognition and behavior in order to improve the outcome. So we moved to a model of Fragile X syndrome. So this is a common genetic disorder that's associated with cognitive impairment and autism. It's the commonest monogenic form of autism. So we got a rat initially with Fragile X syndrome, and we tested them in a sociability task because people with autism are not sociable. And what you ask is a rat to either play with another rat or an object. And if they prefer a rat, they have a high discrimination index. And what you can see is the FMR animals really don't like the friends as much as the toys. They're less good in a Barnes maze, which is like a water maze, so they don't learn cognition very well. And this is an anxiety task. Rats like to live in the dark. And if you have a box which is partly dark, partly light, if animals are anxious, they really don't want to go into the light bit. And the Fragile X animals are anxious. So this kind of looks like autism. We were pleased with that. We then went ahead and did similar neural dynamics type of things. So we measured single units in the brain again. We looked at theta modulation in the hippocampus. And now, unsurprisingly to me, and hopefully increasingly unsurprisingly to you, there is an abnormality of theta modulation here. We then looked at other things as well. So we looked at how similar the neurons were. So when a neuron made theta modulation, did it make very similar theta modulation to the other neurons, or was there variance? And in fact, there's much more variance in the FMR animals. And then here we looked at population coding. So we simply looked to say, if you take two firing trains and correlate them together in a cross correlation, do you get significant correlation or not? And this is the proportion of pairs of neurons that were significantly correlated. And again, the controls are much better correlated than the FMR knockout animals. Okay, so at this level of the microcircuit in hippocampal CA1, there definitely seems to be a problem. So how do we go about fixing this? And brain stimulation is the obvious place to think about, although I'd say we could think much more broadly than that. But for the purposes now, we need a brain stimulation. And what I want to do is stimulate some input structure to the hippocampus, observe some output phenomenon, and then put another input to the input structure and dance with it. I don't know which is going to be the right one. I need to explore some space of stimulation, what frequency, what amplitude, until the system does the thing that I want the system to do. I'm going to dance with it and look for behaviors. So the first thing we did was just take rats, normal control rats, implant them in the hippocampus where we're recording single units, and then stimulate across a range of frequencies to see whether the way we danced with them altered the way those neurons were firing. And what we did is we took these rats, we stimulated them between 4 and 12 hertz. We looked at an output measure of that. And what you can see is the output differs as a function of what stimulation we're putting in across a small range. Across 4 to 12 hertz, you're getting really big swings in how this network is responding to the inputs. And if you actually look at the timing coding again, the theta modulation is much more at 7 hertz than it is at 10 hertz in that animal, much more at 7 hertz than it is at 9 hertz in this animal. So yes, we can dance with it. I don't know whether this is impacting cognition at this point, but as a proof of principle, across a relatively small range of frequencies, I can see big changes in the output. This is complex adaptive system. This is what they do. Small changes in input can have big changes in output. In a different animal, we looked at some place cells while we were doing it. So at baseline, at stimulation at 7 hertz, at stimulation at 5 hertz. And again, you see that at 7 hertz, we picked 7 because of this. At 7 hertz, you're getting some improvement in the place cell of the 5 cells that we recorded. At 5 hertz, it happened to be one where 5 hertz wasn't wasn't predicted to do very well. And in fact, it doesn't do very well. So you're seeing it kind of at timing dynamic, maybe a bit at rate dynamic. There's something here. There's something about the stimulation that's at least tantalizing. It encourages me to try and go after this. There is some human work trying to read EEG activity and use that to determine whether you can change the EEG activity or predict an outcome, stimulate and improve an outcome. So this is work by Eziat. It's a task where people were given a string of words, then a distractor, and then they had to recall words whilst EEG was being recorded. So this is multiple electrodes, multiple frequencies. And what they did was effectively use machine learning to find a classifier that said, when the EEG looked like this pattern, people were likely to recall the information, and when they looked like this pattern, they were likely to forget the words. So when they looked like this, give them a stimulation to see if they changed to this and could recall words, and they can. If you capture this and stimulate, you get some better recall in words. This is a beautiful human proof of principle. It's not very generalizable because this was very determined by the task. You had to be in this task for the machine to learn it. And we are not going task by task by task in life. We have this much more ephemeral, generic thing, pervasive cognitive thing. So I think it's a really important study, but doesn't really take us very far. So what we did was take these FMR animals. So now we're using FMR mice. And we tested a range of stimulations. So we stimulated so we had controls, and this is in a novel object recognition task. All you need to know is that this is a task of memory again, just like a Barnes maze, like a water maze. They're all doing the same thing. So what you see is the FMR animals are worse than the controls. If you stimulate them at 20 hertz, 7.5 hertz, or 75 hertz, you get no particular behavioral change. If you stimulate them at 35 hertz, they get back to more like a control. The important thing to know here is we didn't stimulate them during the task. So we took these animals, we stimulated them for 30 minutes at whatever frequency. Before they actually did the task, they were just wandering around in their home cage. We then disconnected them, put them inside the box, and they did the task. So this is not a direct function of stimulation. All we've done is danced with the system and asked the system to produce something emergent that looks like memory. And if you do it at 35 hertz, kind of looks good. So then we said, is this generalizable? Is it just a memory thing, a one-off memory thing? So here we've done a social discrimination task. So this is the 3 boxes. Does the animal like to play with his friends or an object? Control, friends, knockout, object, knockout, stimulated, friends. We did an extension to that study here, which is, do you want to play with a friend or an object in the first day? The second day, we said, do you want to play with your old friend or your new friend? And rats like novelty, so they were expected to go for a new friend. Controls, new friend, knockout, old friend, or no friend. They basically didn't like anything. Knockout, stimulated, new friend. And again, stimulated before, not stimulated at the time they're doing the task. We did a Barnes maze. If you stimulate the knockout looks like this in the Barnes maze. The control looks purple. The knockout stimulated, almost identical. And again, not stimulated during the task, stimulated before the task. Okay, so it looks like there's something interesting about 35 hertz and FMR knockouts. Do I think that's going to be absolutely generalizable to anything? Do I think 35 hertz is beautifully magical? Probably not. But what we're showing is this principle, that we can dance with this system and we can make it change its properties. We can allow it to self-organize in a way that it wants to optimize. Brains want to optimize to be able to do this stuff. So if you bump it, it wants to optimize. If you find the right bump, it's going to optimize. This is the principle that we're working on at the moment. So we don't have any in vivo electrophysiology of those animals. We decided to take an in vitro approach first and do an LTP experiment. This was just a straightforward LTP experiment. Again, we stimulated for 20 minutes, extracted the hippocampus, took a slice, did an LTP experiment where you stimulate tetanically, you observe what happens with stimulation in terms of the EPSPs. You then do a tetanic stimulation, look again, and you'll get a change in the size of the EPSP. Controls have a change of the EPSP that looks like this. The FMR animals without stimulation have a worse change. The FMR stimulated animals look like they're doing better and look like they're closer to control. So is there an electrophysiological output of this stimulation? Yeah, sure looks like it. So that's as far as we've got with these at the moment. We're obviously wanting to move to looking in vivo and looking to see whether this generalizes across other animal models, other things like that. But as a proof of principle, I think this is really important for thinking about developmental and epileptic encephalopathies. So I hope what I've been able to do today is show you that the concepts of DEE have really evolved enormously and they really continue to evolve. I've tried to persuade people for a long time that the role of the seizure and the epileptic discharge has been overstated. And I really want us to move away from the idea that we're going to gain huge amounts by chasing down epileptic seizures. We should step away from that. I think the two big options for us are the rise of genetics and the potential treatments. And will we find some gene therapies that work? Maybe. Are we going to find precision therapies that are amazing? Hopefully. But I don't think that's going to ever be the entire answer. The magnitude of the problem, the number of gene abnormalities, makes me think we're going to have at least some alternative or some orthogonal approach to this. And for me, that's this complex adaptive systems formulation. This, I hope, has shown you can lead to some novel insights and can lead to some treatment ideas which are not currently out there for DEE. And I think the concept is certainly worthy of further study. So I'm just the mouthpiece, as is usually the case for many of these things. So much of this work was done by a variety of people, both at Dartmouth and now more recently at Nemours. The big collaborators are Matt Mahoney, who's a mathematician, and Amanda Hernan, who's a neuroscientist. And together we've really built these ideas and these programs. A variety of people have done the experiments, and the current person who's doing a lot of the experiments on autism is Mohammed Wadouz, who's in my lab. And with that, I'll take questions. I hope I haven't overrun too much.
Thank you, Dr. Scott. We are at time, so if people have to leave, that is okay. But Dr. Scott, can you please stay on for a minute or so if we have any, I don't know if we have any questions. Dr. Skidmore did message a question, but if there's anyone else who has a question here, we can start with that.
We can start with his. I know it looked like he had to go just because we were at time, but it was great. I'm glad everybody could stay on. He was asking Rod how durable the effect of the stimulation was. So this will then be recorded so he can see the answer later.
The answer is
Don't know.
I have absolutely no idea. I'm trying to dance with the system. I'll dance with it a bit longer and look for durability. All of those things are the questions. This is really at the beginning. We're at the very beginnings of pursuing this. Yeah, we'll know soon enough.
Any other questions? I just had a quick question. I think, obviously this is kind of a moonshot idea, and I really love actually the concept of, not necessarily being linear. As we talk to our patients about genetic testing, I'm on the adult side. I think we're telling them that this is still an area that's really TBD. But what do you really envision as, I know the cliched term is often personalized medicine, but what the assessment might be for a child or maybe an adult of how the genetic results would be embedded in the other clinical testing that we do?
Okay, I'm smiling because there's several people online that know my view about genetic testing. I largely don't do it. Mm-hmm. I don't think there's much value in it. What I take away from it is you get a string of letters and numbers, which doesn't give you much predictive value in terms of outcome or treatment or anything else. So I think once somebody's able to show me that there is a very positive effect from doing a genetic test and this has impact, then I'll be more inclined to do it. At the moment, the way I talk to parents is saying exactly that. I can give you a string of letters and numbers. Let's go with JAK23. That seems to be a good one for today. We'll call your child's disease JAK23, and that carries as much information as the gene information. That's probably overstating it. I mean, the gene obviously is important. I think the idea that I'm trying to impart is the gene is not everything. And even if you want to live on that side of the coin, I think you have to acknowledge that it's not linear, that you can't look at the gene and in some linear way predict what the child's phenotype is going to look like. If you can't do that, it's not entirely obvious to me why we think we can replace the gene and linearly predict that we're going to fix the patient.
Yeah, I appreciate that. Real quick, just in the interest of time, I mean, our geneticist extraordinaire, Pete Greeno, who's in our group, is actually out of the office today. I'm sure he'll watch this later recorded, but I know that, just for the trainees, there obviously are some practical uses, like, for example, for Dravet's, right, where you might then avoid certain medications. And I know he often talks a lot about with patients about using it to sometimes get connected to certain support groups. That certainly isn't therapy, but in the way that we would traditionally define it, but sometimes that can be useful for patients and their families or caregivers as well. But anybody else have any?
That's fine. I just want to make a quick comment on that. So I don't object to people using genes. And if they want to find a gene and say that helps me to decide what drug I shouldn't use, that's fine. I think I can generally do that clinically. I generally don't think I need a gene to help me to do that. But if that's helpful to an individual provider, then absolutely go ahead and do it. I think the idea of family support groups is again embedded in the one gene, one disease idea. So what you have is people with one gene, multiple different phenotypes all coming together saying, we've got this really important thing. The gene is the thing that's important that determines our children. And then they talk to each other about their children who are not remotely related to each other. And I think the support group that's missing, and it's missing because of this type of structure, is the support group that says, well, you have a developmental and epileptic encephalopathy. I don't give a damn about your gene, but all of you kids look the same. If you want to get some family support on how you manage the kid, then you don't actually want to define that by gene. You want to define that by phenotype.
Yeah,
Fair enough.
I just have a quick question. Thank you. That was an amazing talk. I really enjoyed it very much. Are there data from the single gene data treatment that an earlier treatment is better? That, I mean, it may be that it's too late at a certain point. Are there strong data or any data really supporting very, very early treatment for epileptic encephalopathies?
So I don't know that there are data. It's certainly out there as an idea. I think it's a slippery slope to saying, in the end, when is early, because brain development happened in utero for 9 months, and all of it's already in the context of whatever mutation there is. So it kind of takes you to the only way to have babies is IVF, which I don't think any of us are actually going to buy. So I don't know what that means, and it doesn't predict. So we can't even say I'm going to do a whole exome and replace the gene in a baby in utero, because we have no idea most of the time what the outcome is going to be. You can't look at an SCN1A mutation and have clarity on whether you think it's going to be Dravet or GEFS plus or a febrile seizure. So I think, yeah, my big point is all of that is formulated in a reductionist framework. All of that is formulated in the way that the element is the critical thing. And I'm trying to persuade people that the system is the critical thing. The element is just the perturbation. There's many, many ways to perturb systems, and that's what we need to get to grips with. But it's actually the system that we need to be understanding.
Thank you.
All right. Well, thank you for your time, Dr. Scott, and for a great talk.
Thank you very much.
Have a great weekend, everyone.
Bye.